without much time spending, I'll start off with my talk. As I said, the color or the density or the hardness of the cataract is no reason to not do phaco today. To answer this question about how hard is hard, there is no specific classification available in literature. It is very relative. It's relative to your experience. It's relative to the ocular condition, the expectation of the patient, and what you feel you can deliver in your clinical or hospital or clinic or surgical scenario. So it's very important that as a phacosurgeon, you know your strengths, you know in which scenario you're operating. For example, if you're in an institution, you might have other seniors to come and help you. You should know when to bail out. So these are important factors. Next, very important thing is you must have a good preoperative ocular examination done. So if you're dealing with a compromised endothelium or pseudoexfoliation or senile meiosis, those might make the situation even more difficult than the cataract already is. So you might not want to do in those situations. The very important that we spend a lot of time in counseling the patients that they might need a second surgery, a bailout surgery, and so on, so that the patient understands the clinical scenario where we are delivering. Most of us do phacoemulsification today under topical anesthesia, but this is a difficult scenario, so you should not hesitate to give peribulbar. There is no ego here. The last point which I wish to make is what will be the approach? Should it be superior? Should it be temporal? Should it be corneoscleral tunnel or clear corneal? Is each individual's expertise and comfort zone. Personally, I do temporal clear corneal for all clinical scenarios. The next important thing is whether it is brown, black, or white, I stain all the capsules because one gives a good contrast, and not just for doing the capsular excess, but even afterwards while doing the vertical chop. I'll show you in my videos in the next slides. It shows a good contrast, so we are able to see the capsular edge almost at all points, and we can take care in not damaging the capsular edge. Very important use is the use of ocular viscoelastic. Most of us use methyl cellulose for routine phacos, but here I would use a thicker combination of chondroitin sulfate, sodium hyaluronate. The chondroitin sulfate coats the endothelium very well. The combination together maintains anterior chamber very well. Sodium hyaluronate alone would also probably be a good space occupying viscoelastic, but it will come out very easily, whereas a combination with chondroitin sulfate does not egress very easily. So it stays in the chamber and it coats the endothelium as we do the phaco. The other important thing is even in the middle of surgery, you could come out and refill, so that because there is no epinuclear bowel to protect, and this acts as a good buffer against the PC when we are doing the last few pieces of phacoemulsification. So very important is to choose the thing. Here I'm showing a video of the next important step, which I wanted to show is hydrodissection. So before I start the video, let me just explain to you that there are two aspects you must remember. That the chamber has already been pressurized with some heavy viscoelastics. So adding more fluid to it, you are increasing the intra-chamber pressure. So one is that. So you must decompress the chamber. Number two is there is not much space between, as you can see here, between the rexus, because the nucleus is huge. So you must learn to decompress the nucleus center so that the fluid does not collect between the nucleus and the PC and causes a PC rupture. So as you can see here, the first thing is to decompress the anterior chamber a little bit so that there is an egress. And then you go right inside. There is no role of hydrodelineation here. It's only a hydrodissection. There you can see the slight rise in the nucleus as the fluid wave goes behind. And then you press the center to ensure that it's released and there is no trapped fluid within. The other thing you could do at this stage is you could put a Sinskey's hook and rotate the nucleus to confirm that you have achieved good hydrodissection, refill to coat the endothelium with chondroitin sulfate, and get ready to proceed with phacoemulsification. Here, again, a very dense, compact brown core presented as a white cataract in a 70-year-old diabetic. Diabetics usually have a thick posterior plate. I tend to do a crater or a wide, small tunnel to give me the space to do the vertical chop. I'll pause the video here because I wish to point out that I make the left-hand side entry close to 90 degrees away. That's because I'm comfortable that way. I put in the second instrument a little later because what I wish to point out is you could make the stab entry later after you have started the trenching. Some might want to do it very close to the main incision to have a almost in the same axis as the phaco probe, and some might want to do it away. You could vary the second side instrument based on the ocular condition. In deep set eyes, you might find it very difficult to go full 90 degrees. So this is one point I wish to make. The second thing is I would use continuous mode here, lot of power. Impaling is very important. Keep the probe impaled and dig in with the vertical chopper. I use a vertical Mohanrajan chopper, which has got a long tip and a sharp tip at the edge. So you chop all the way down and ensure that the posterior plate has separated. Normally, I would not remove the pieces, but go all around chopping. But in some situations, I eat off at least one small piece because it gives some more room for the nucleus to rotate. And you proceed in removing small segments of this, and watch that we are doing it fairly deep, because there is good chamber stability and we are not catching the top of the piece but the bottom of the piece, so that the endothelium is protected. And because there is adequate chamber stability, we can visualize that the PC is far away, we are in safe territory, doing all the emulsification in the center. And one needs to emulsify, only then the piece will go inside, otherwise there will be stagnation and the piece will not enter and get emulsified, and the port will get clogged. At this point, I wish to just point out here that I use a Venturi system most of the times. Any of the systems today, it's not Venturi or peristaltic. One is not better than the other. You could change the settings to achieve equal performance. And here I would use a lot of burst mode for impaling the phaco probe. And I don't know if it's visible here, about 60 pulse per second is my hyper pulse mode while you chew the pieces away. Because by using pulse mode, I have seen that there is less chatter and good followability of the pieces as they go. And you can see here that both have got only 40 power. You don't need much power when you're chopping, and you're using a high vacuum and pulse mode, hyper pulse mode, to take the pieces away. Remember that there is a role of chopping and sub chopping which you need to do to make the pieces smaller. And I wish to point out here that as I'm chopping, you can see that we are separating the central disc away. This central disc can be confidently emulsified because there is a lot of buffer behind it. And once this is taken away, it kind of breaks the back of the nucleus, as I call it, and the rest of the nucleus emulsification is fairly simple and straightforward. In the peristaltic kind of machines, I use 440 aspiration flow rate. The aspiration flow rate must match the vacuum, otherwise there will be a lot of turbulence in the anterior chamber before you can get adequate and easy performance in these kind of cataract situations. So now I'll move on to certain video clips that I have of surgeons whom I have supervised, and certain small what not to do kind of situations I'm going to show. So again, white cataract with a compact dense core, and one must use high power so that there is no rocking of the nucleus, number one, and the trench which is made should be wide enough to accommodate the phaco probe inside. As you can see, the surgeon is still skimming in the surface and rocking the nucleus, which might cause some zonular harm if this is continued. So you might need to either increase the power or make wider trenches so that the phaco probe is able to sculpt through the dense core in the center. So important message here is do not rock the nucleus. Next thing here is very important in all these clinical scenarios is to not have or recognize the formation of cataract milk. Cataract milk is that emulsilate which forms, which is evidence that there is a heat generation happening because the outflow is not happening adequately. Here you will see as the surgeon is trying to chop, there is a little, there you go, you can just see that the little cataract milk came out. Persistence with the phaco power at this stage will cause probable wound burn to happen, especially in these kind of scenarios where we do clear corneal cataract surgery. Another situation where I want to show that in situ chopping must be done. Once you have impaled, you must chop at that point while the surgeon continues to pull back out of the fear. And you will see that the port gets blocked in the wound here. And then as they try to go back inside, they have caught the piece of iris there, the pupillary margin. And this in turn, with the persistence, has created an iridodialysis. And these kind of situations are disastrous. What the surgeon should have done once they had impaled is done the chopping procedure there itself in that position and not pulled back. Another thing I wish to show here is where the surgeon tends to, again, this is just that you need to be a little bold, little lack of confidence. So they tend to rotate the nucleus into the anterior chamber and attempt the chopping in the anterior chamber, thinking it's very safe. But Lord save the endothelium in this situation. So I just wish to share that whenever there is unstable anterior chamber, most of the situations today, we don't have unstable anterior chambers because we have these microflow tips and ABS systems. You could increase the bottle height and lower the vacuum. Similarly, sometimes the vacuum might be there, but there is no followability. In those situations, you might want to stop, refill with viscoelastic in the anterior chamber, irrigate the port so that the clogging of the phacoprobe has not happened, and then continue the procedure, making sure that you have not had a PC tear, because if there is vitreous strands in the anterior chamber, it's going to prevent the phacoemulsification from happening. And I think there, just to summarize now, do not hesitate to give peribulbar anesthesia. Do not hesitate to create a scleral tunnel. If you feel you might want to have a bailout option in hand, that's a wonderful bailout option. You could convert to an SICS and deliver the pieces out if they are not getting chopped or emulsified easily. Do stain the capsule, use heavy viscoelastic. These are the two probable things you should work towards: is do chopping, preferably a combination of vertical and horizontal chop. Do sub-chopping to have good results. Use hyperpulse and burst modes. And lastly, remember, there should be no ego, and at the same time, there should be no fear when we attempt any of these high-risk situations. You must also remember to take the help of your senior colleague should the need arise, even in the middle of the surgery. Thank you very much.